this session right. There we go. Awesome. So good afternoon, everyone. I think I know a lot of you guys, but my name is Crystal Wong. I'm a family doctor. I practice at UW-PC Ravenna. And I'm also the Associate Medical Director for Digital Health. I've been with UW since I came here to do my residency training back in 2007. And so I'm going on about 15 years with UW, so a lot has changed. And I am here to train you on some new stuff, the ever evolving way we deliver care to our patients. So again, today, I'm here to focus on the provider part of remote patient monitoring. We'll do some introductions. We'll give you some good background. Just know that your RN and your nutritionist have already been trained, as have your clinic leadership. There was a large group training. So today we're going to really focus in on what you need to know as a provider. So why don't we just start with some basics? So what is remote patient monitoring? I think it's probably something that a lot of you guys have been doing informally for a long time. I know my patients will, send me, data from an Apple Watch or something and expect me to know what to do with it. Well, this is a more formalized version of that. So we're going to focus in on what's called continuous glucose monitoring. It's a specific type of remote patient monitoring. And this is where a patient will use a glucose monitor to manage their glycemic control, basically, and send that data to the care team. One of the benefits of moving to more chronic disease managed with remote patient monitoring is that it brings the care of the patient into their home. I know that it can be kind of frustrating to try to get through everything. People's lives are complex. There are many factors that go into health and wellness. And you only have a very small snapshot of what's going on in their life. Well, remote patient monitoring programs help bring the medical care into the patient's natural environment, into their home. It's also a way for us to harness our teams in a way that is increasing scope, partnerships, spreading the responsibility and the work. And I think that's something that we feel acutely in primary care is, sometimes it feels like we're shouldering the weight of the world for these patients. And so this is the way to kind of bring our care teams together and work together for the patient. We are hoping that programs like this help reduce the amount of in-person visits that a patient needs. I think there's a lot that can be done through other modalities than, having to bring in a patient every single month to talk through, glucose reports, et cetera. Okay, so this is the components of what we're going to talk through. We're going to talk through the CGM workflow. We're going to talk about identifying, outreaching to, consenting, and enrolling patients. We're going to talk about data submission and upload, as well as how to interpret data. And then we're going to talk about just facilitating all of that communication that goes around changes to care plan, working with the team, et cetera. And we'll spend a little bit of time talking about coding and billing. I want to also just say, Mika will be watching the chat, so if you have any questions, you can type them in there. Also, feel free to interrupt me if there's any point of clarification. Okay, so I'm not going to go through this slide in super deep detail, but for those of you guys who like flow sheets, who are visual learners, this might actually be a good tool for you. And this is basically an overview of the whole process map of what remote patient monitoring for CGM is going to look like. And you can see that this is divided into what we call swim lanes, and that equates to the role, the role of the team member and what they're responsible for. So you can see the top row over here is clinic, MA, RN, and RD. Next would be patient responsibilities. Next would be provider responsibilities, panel navigator responsibilities. And then also down here, we've just got like the little, equivalent box of where the codes are and what part of the process you would build that out. So this is part of the toolkit we have for you guys if you want to print one and have it in clinic or whatnot. We actually built this for the pilot we did. We actually ran a pilot looking at CGM, RPM before, deciding to go live throughout UWPC. And we actually built off of the Visio we built for the pilot and enhanced some steps, especially around this area right here, which is getting equipment covered for patients, making sure patients have all the necessary material or paperwork or chart notes, et cetera, that they need to get their insurance to pay for CGM. Okay, so, who should be part of this program? Who's included in this program? And I want to make a clear distinction. We're going to dive into the next couple slides in pretty big detail, that there's a difference between medical eligibility, meaning who would actually be a good fit from a diagnosis perspective, from a clinical perspective, from a value perspective, as to what insurance will cover. Okay, so I think the construct that works best for me when I'm thinking about this is kind of like you're trying to prescribe like a new medicine that works really well for this condition, but maybe some insurances haven't caught on. It doesn't mean, just because the insurance doesn't cover it, doesn't mean that the patient wouldn't benefit from this, better medicine. It's just maybe, there are certain criteria they have to meet in order for insurance to pay for it, or a prior authorization process for them to get covered. So similarly for coverage for the equipment, okay? So why don't we start with medical eligibility? Who would be a good fit for this program? So first and foremost, we are focusing on patients with type 2 diabetes. Continuous glucose monitoring is standard of care for type 1 diabetes. Basically, if you're a type 1 diabetic, you use an insulin pump or a multi-dose insulin, whatever. Standard of care for type 1 diabetes is using CGM. We are not including them in our pilot because this is very primary care focused. And, most patients with type 1 diabetes are seeing an endocrinologist and getting that managed through there. I know all of us do maybe have some patients with type 1 diabetes that for whatever reason don't want to see endocrine, and we're managing them. I wouldn't include them in this program since, again, this is a very regimented, a very standardized program. You'll have to use your best clinical judgment on, what you're going to do with that type 1 diabetic that you're helping, but don't enroll them in this program. So your patient has type 2 diabetes. Next is, they meet one or more of the following criteria. I think the most typical patient for this program is someone who's on insulin, and that's probably what pops first to mind. But they don't have to be on insulin. There's actually a lot of really good evidence showing that continuous glucose monitoring, even for patients not on insulin, is a really good tool, and it has shown statistically significant improvements in A1C, even in patients who aren't on insulin. And I think because it's just a very engaging tool for patients who are trying to titrate lifestyle, build new habits, remember to take their oral medications, et cetera. So they don't have to be on insulin. They can be on insulin, but they don't have to. Additionally, this is really good for patients who are having difficulty with glucose management, and that's either hyper or hypoglycemia. I know all of us maybe have some patients that's been very difficult to get them to use traditional finger stick glucose checks. This is a great program because you don't have to poke your finger for it. Also, just anyone who's just not at diabetes goal. And then the last category would be someone who really wants to tailor their lifestyle to glycemic control. And I know personally, I was in one of the clinics that went through the pilot, and I enrolled a lot of patients who had just newly been diagnosed with type 2 diabetes and really wanted to try lifestyle before starting to take medicine. I also enrolled a couple of patients who I just started on metformin, so we could kind of see the difference in their glucose control on the new medicine, et cetera. So just know that the inclusion criteria for people with type 2 diabetes is actually quite broad. Okay, so people who are excluded. So again, people with type 1 diabetes, patients who are already receiving care from endocrinology. So if you've got type 2 diabetes and they see endocrine, they can talk to their endocrinologist about participating in this type of program, but we're not going to include them in our program. Also pediatric patients and gestational diabetes, that's really out of scope for right now. Some good places to find patients, you might have some complex patients with diabetes who are already enrolled in care management. That's always a good place to start, especially since this program is very collaborative with the clinic RN and RD. Also, if you're doing your panel management meetings and you're working with a panel navigator to run your diabetes list, to take a look, see if any of your patients who aren't meeting the A1C goal might actually be a good fit for this program. Okay, before we jump into insurance coverage, any question about medical eligibility for this program? All right, so now let's talk insurance. This is where it gets complicated, and this is where I think providers kind of get uncomfortable or don't like to have to manage these complexities. Insurance coverage for CGM equipment is getting better. I think hopefully in a couple of years we won't even need to harp on this. It'll just be a easily covered benefit through Medicare and Medicaid, et cetera. But right now there are some hoops to jump through. So first of all, if you have commercial insurance, your Regences, your Uniforms, those types of insurers, as long as you have a diabetes diagnosis, doesn't matter if it's type 1 or type 2, they're going to cover your equipment. Now, obviously, there's some patients that have high deductible plans and whatnot, and we never want to guarantee how much out-of-pocket costs would be, but in general, commercial insurance will cover equipment. There may be some sort of copay associated with it, but they'll cover it. Medicare gets a little bit more restrictive. You do need the diagnosis of diabetes. You need to be using at least TID insulin, and you need to, quote unquote, need frequent insulin adjustments. That's completely subjective. This is why and I'll talk to you more about this later, but we built some Epic tools that'll help kind of check those boxes for medical documentation, because the process that we did construct to help support patients getting coverage for their equipment needs chart note documentation. So our smart texts that we built for this program have language in there so that the prior auth team can just print that note and kind of have all the things that the insurance needs in order to get this covered for the patient. Medicaid is the most restrictive payer. Now, I actually just got some emails this week from my boss, John Scott, who's the medical director for digital health. And there's been some strong advocacy for Medicaid programs to cover RPM better. And they're actually pushing through a bill for the Washington state legislature. So hopefully Medicaid maybe shifts to the other side, with commercial, and it's just easier to get this covered. But again, there is a lot of advocacy and movement towards acceptance of RPM as standard of care because the outcomes are really just so good. But for now, you need the diagnosis of diabetes. You need TID or greater insulin, you need frequent insulin adjustments, and you also need to be self-monitoring, so using finger stick glucoses, at least QID, or at least recommended from the provider that you be doing this QID. So anyway, so it's complicated. I'm going to talk through the workflow, like what's going to happen behind the scenes, but it's just something that we need to be aware about. I do want to just mention also that I'm just talking about the equipment, okay? The codes that you bill for interpretation, the codes that your RN or RD can bill for the time they spend downloading data for you, putting stuff in the chart, talking to the patient, all of that has actually been uniformly well covered by every payer. And we know this because we actually ran a hypertension remote monitoring pilot as well. And every payer, Medicaid, Medicare, commercial, we're paying these codes very well without any denials. The really sticky situation for this program is really just getting the equipment covered. Now, some patients who maybe don't meet the insurance coverage criteria, but still meet our eligibility criteria, might be willing to self-pay, especially because there are good coupons available online. A lot of times, Abbott actually offers either free or very reduced cost sensors for patients. GoodRx is always a really good resource that can bring down the cash price. And so sometimes patients, especially those who maybe have a new diagnosis of diabetes and just want to get a grasp of what their what their glucose control is looking like as the day goes on, how it responds to meals, how it responds to exercise, et cetera. They might be willing to, self-pay for, a month's worth of sensors. That's just 2 sensors, gets you through a whole month, or whatnot. So, I think that's a conversation if their insurance is going to be a little bit difficult to get covered. So when you identify a patient, what do you do next? So one thing would be consenting the patient. And because this is a referral to a kind of a special service that we're going to build to insurance, we do have a consent built. So there's a smarttext.rpm consent that has some compliance vetted language that would meet the criteria for gathering consent. There's also a referral to RPM that you would order. This is, following the same workflow that we constructed for something like referral to care management or referral to BHIP services. So hopefully this kind of meshes in your clinician mind that like fits into the usual kind of flow for ordering services. And then there's a dot phrase, this one right here that says .cgm RPM enroll AVS. And this is your dot phrase that has all of that language so that the prior auth team, when they get the request for the equipment for your Medicaid or your Medicare patient, they have all the medical documentation in the chart note, so they can just print that chart note and send it to insurance. So I believe it says something like, I am the PCP, I'm ordering this as a medically necessary service. My patient uses insulin, TID or more times a day and needs frequent adjustments. So it has that language in there, so you don't have to remember it off the bat. So again, we're trying to build as many tools as we can to make this as easy as possible for the provider. There is a little bit of weirdness with the Medicare order. So for commercial insurance and Medicaid, you order this in Epic just like a medicine, just like you're ordering them their metformin or their insulin. You type in their Libre 2, it pops up the order and you sign it, and it goes to the patient's pharmacy. For Medicare, the CGM RPM benefit is through their DME benefit. So they can't just go pick it up from a pharmacy. The patient actually has to take an order and give it to a medical supply company, similar to, if they were getting a pair of TED hose or a cane or something. So the way that you can do that is a couple ways. One, you can absolutely use the same Epic order as if you were sending it to a pharmacy, but just choose the print option. So then, it prints the prescription on a piece of paper and then sign it and give it to the patient. You can also put in a DME order if you'd like and print that and sign it and give it to the patient. There is additional DME form. And if you're using the standard smart text for this program, it actually has a hyperlink that you can just click it in the smart text and it'll pull it up from, it's actually housed on the UWPC SharePoint site. But it's a PDF, and you can see there's that little hyperlink in the slide right here. And you have to fill that out and give that to the patient. The patient also gives that form plus the prescription to their medical supply company. This also the last thing you can see here in yellow. So if the patient has a smartphone, they actually just use an app on their smartphone, and that's what syncs the data from the sensor that they wear on their arm. If they don't have a smartphone, though, then you have to also order them a reader. And shown on this next slide, it has the Epic orders here. So you'll see this upper left-hand corner, it says Freestyle Libre 2 reader. So that's the device. So that's what you would order if they don't have a smartphone. If they do have a smartphone, then you can just do this sensor 2, the Libre 2 sensor, miscellaneous. And one sensor is 14 days, so 2 would be a 1 month supply, and then you can choose how many refills, etc. So if they have a smartphone, all you have to do is order the sensors. So what happens behind the scenes? So you send the referral to RPM, that goes into your nurse's actual care management work queue. They're used to using that for care management referrals. And then they'll review what you have in Epic. They'll review your chart note that's, associated with you talking to the patient about this and offering it to them. They will check the orders and see if you actually put in the orders for the equipment. If it slipped your mind and you didn't put it in, then they'll actually go and pen you the orders, and then you can co-sign them for the patient. If they do see that you ordered it, the next thing they're going to do is they're going to call the patient, and they're going to check in on the status of the patient being able to pick up their equipment. So, hi, Mrs. Smith, this is, nurse from OPMC. I see that you're enrolled. I'd like to get you scheduled, but first, can I check and make sure you picked up your equipment? Did you get your sensor? And if the patient, typically, if either they have commercial insurance, so they're able to just pick it up like a normal medicine, or if, the prior auth process has kind of kicked in already, they'll have their equipment, and then your RN or RD will go ahead and schedule an intake appointment and make sure the patient brings their equipment in because they're going to do training for the patient on how to put their sensor on, how to sync their device, et cetera. If they haven't gotten, received their equipment yet, the RN and RD is going to step in and help the patient. So what's happening on the back end, and this is exactly what happens, right? If you send in a prescription for a patient and it needs a prior auth, and it goes to the prior auth team. So the prior auth team will get that need for a prior auth, and they'll go in and they'll pull the chart notes, they'll put together the packet that the patient needs for either Medicare or Medicaid and send that off for approval. And this was actually a big lesson learned. It was a little bit of a black box for us of like what insurance needed and how difficult was it going to be to get it covered, once it kind of went into that PA black box. But the pilot was really good for ironing out the steps. And so Ellen Kahn and the PA team and the nurse and RDs really put together a good workflow. I don't have the Visio for that specific workflow in this presentation, but if you guys want to see it, it's available. So fingers crossed this works better, while we're kind of in this period where, insurance are still making us kind of jump through some hoops for coverage of equipment. Okay, we talked about that already. Any question about that? I would say that's the most confusing thing about RPM is frankly just getting the patient their equipment.
I have a question. It's generally about the referral to RPM. I was just checking out platform, and there are a lot of clinics there that we can choose, but the OPMC clinic is not there. So I'm not sure which one we have to choose working in outpatient primary care Northwest for the referral for the RPM.
Oh, sorry. Can you clarify? I'm sorry, I'm not understanding your question.
So I just did refer RPM order, and there's no location in our clinic. I'm not sure if our RN also will be,
yeah, you don't have to choose the specific clinic. Yeah, you just choose the program. So Epic on the back end, if you're signed into your OPMC department in Epic, that it'll go into your nurse queue there. Does that make sense? You don't have to choose the clinic location. It should only have 2 drop downs right now. Actually, it should just have hypertension or CGM, and you would choose CGM.
So I have an order for RPM, and it pops up different location: Ballard, Belltown, Victoria, and probably I can just UW General IM, something like that. If you're not choosing.
Oh, that's interesting. I wonder if you're not. Hey, Mika, can you take that offline and clarify what the RPM referral looks like? Because I don't think it was location specific, but
I can share my screen if you would like to see.
Yeah, I want to make sure I get through the rest of this presentation. I think Mika, you can probably talk and check in Epic and just see how it looks like, but. Yeah, we can make sure that it's queuing to the right place. I think Tammy and Allison had looked through that, but we'll clarify that offline. But yeah, thanks for being in Epic and looking at it.
Crystal, this is Allison, and I just wanted to make a quick note about before you move forward any farther, but in
Yeah.
terms of when they place the referral, it's just really
Uh-huh.
important to CC both Christy
Yeah.
and your nurse, because at your clinic, Rachel is still getting kind of up to speed on this, whereas Christy has done a lot of CGM start. She hasn't done the billing side of it, but in terms of helping both of them get up to speed, if you guys could, when you're routing your chart note with the referral in it, to see both of them at least in the beginning, it'd be great. And I'll
Yeah.
divide and
And I
conquer
think I have,
together.
yeah, I think I have that in multiple slides, but I will also underline and bold that, you know, wherever you are in terms of bringing a patient into this program, your RN and your RD are going to be really, really critical team members, and, you know, make sure that you're communicating, because, you know, they need to know what you're thinking. They need to know your plan, specific plan for the patient. So once the patient has everything they need, we know that they have their equipment, the RN or the RD is going to schedule this intro meeting. And predominantly this meeting is to train the patient on how to use the equipment and how to review your specific plan for the patient and their diabetes care. There is some teaching, goal setting, history taking that can happen. But you know, it kind of depends on how facile the patient is and how much support they need in training. So it might get split into 2 visits if you know, they run out of time. But you know, I think that it's a really good visit and really important to do this step, and it can actually help, you know, gather maybe a little bit more detail than you'd ever been able to have time to do in your, you know, short visits with the patient. And then just a quick reminder that this has to be face-to-face. They can't do these over telemedicine because it's supposed to be device teaching. So at least under current compliance interpretation of the codes, this has to be a face-to-face visit. The patient is going to actually wear this sensor continuously. After they put it on their arm, it actually is worn continuously for 14 days, and then they switch it to a new one. They do have to sync their device at least every 8 hours, and that's, you know, a key thing that the RN and RD will go through with the patient. If they don't sync it at least every 8 hours, they're going to lose the data. And then, you know, after the patient's good to go, they've got it set up and they're transmitting data, the RN and RD is going to go into the LibreView portal and they're going to input the data into Epic. So this is going to come to you in typically a CC chart. Depends on the outreach to the patient, but you'll get an encounter in your in basket. And it has a specific dot phrase that has the kind of key metrics that we're looking at from the LibreView report. And I'll show you that in a few screens. And it's also got a link to the scanned PDF that'll be in the media tab of Epic, so that if you want to look at the full report, you can click it and then it's right there. Also, we have a new tool. We have a diabetes flow sheet that the RN and RD will be using to input the key metrics, and that way you can actually trend them. So, you know, let's say this is a patient who has been working with you for 8 weeks and you have like 3 GMIs in there. When you go into the flow sheet, you'll actually see the GMIs listed next to each other in terms of trended over time. So that's an improvement than what we have. You know, you can decide how you're going to do your interpretation of the data. We're going to talk through that in the next few slides, but you can do the interpretation right then and there in the in-basket and fill out the charge. It doesn't have to be a interactive interpretation with the patient. But I think a best practice, honestly, is to do the interpretation with the patient, because that's, you know, where you get the, you have the good conversation with the patient that would help go over, you know, any care plan changes, et cetera. This is just a screenshot of what the diabetes flow sheet looks like. If you go to the flow sheet tab in your taskbar in Epic, and then in this little search with a little magnifying glass, you type in diabetes MA note, it'll pull this up for your patient. you'll see these sections right here that are highlighted in yellow. This is going to be where you're looking for your key metrics and a quick snapshot of those over time for your patient. This is actually what the report looks like that your RN and RD will pull from LibreView. And we'll dive into this in more detail. I also have a link at the end of this presentation to a lecture that Dr. Savitha Subramanian did for the pilot providers. It's about an hour long, but she goes into detail on specific cases, interpreting specific AGP reports, et cetera. So if you want kind of a really good clinical overview, right here, I'm going to give you kind of like the basics, but you can watch Savitha's presentation. Additionally, there's a shorter video. It's about 13 minutes. It's by Abbott, the maker of the Libre 2, and it also is for clinicians, and it's directed on how to look at the different parts of the AGP report in detail. I think you guys already have the foundational skills to interpret these because it's basically just better like chem sticks. Honestly, you know, what we're used to now is a patient brings in this little white book and they've got, you know, maybe a few numbers and you need to decide what you're going to do with their insulin or their oral meds or whatever. With this, you know, you get much more detailed information. So the AGP report can be broken down to kind of three sections. One is this glucose statistics and targets. So these are kind of your key metrics. Over here on the right-hand side is the time in ranges, and it breaks down where your patient is, whether they're in their target range or they're high or they're lows, and the percent of time they're in there. At the bottom, you have an ambulatory glucose profile, which is kind of like, you know, just their trajectory over the day. You know, where are they going high, where are they going low, what is the response to meals, et cetera. And this will get marked by the patient on, you know, when they ate or when they took their meds or whatnot. So you can see the key, I guess, you know, things that might trigger either hyper or hypoglycemia marked in the waveform. So the key metrics that you're going to be looking at on an AGP report are thus. So time in range, I think, is kind of a new data that we haven't been able to kind of distill from just, you know, old-fashioned chem sticks. And there'll be a couple of core things you're looking at. One, you're looking at what's called time in range, and your goal is going to be above 70%. Time in range of 70% correlates to an A1C of 7%. So basically 70 or greater, you're going to be hitting your diabetes A1C goals. 10 below range, you know, indicates hypoglycemia. Obviously, this is going to be a little bit more important for patients that are on insulin or on oral medications that could cause hypoglycemia. And then you'll also look at the highs. You can see that portioned out. The other key part of the AGP report are those core metrics again. And this is also going to tell you if this report has enough adequate data that you can make changes based on it. For it to have enough data for you to feel confident that you can, you know, titrate meds or whatnot, you need at least 14 days, and they need to be scanning at least 70% of the time. So remember I said they have to scan their sensor at least every 8 hours, otherwise it loses data. So, you know, if your patient hasn't been good about scanning, you might not have enough data to feel confident of changing their regimen. Excuse me. So you're going to get over here, you know, the amount of time that this report covers, the amount of time CGM is active right there. You're going to get some time in ranges. You're going to get an average glucose right here, and you're going to get this metric called the GMI. That's actually a calculated A1C based on the report data. So you can kind of think about this as a stand-in for A1C based on the glycemic control during this time period. And then you're also going to get this glucose variability. This can help minimize the risk of hypoglycemia for patients who are prone to it because of their medication regimen. So, excuse me, the goal is net less than 33% to lessen that risk. I'm going to go through a quick rubric for how to interpret AGP reports, and if you can follow this stepwise process, you'll make sure that you get all the information you need from the report. So the first thing you would do is you would take a look at the report, and again, you would look right here in the glucose statistics for this info and say, is there enough data to review? Is this at least 14 days? And did the patient at least wear it 70% of the time or more? If either of those are not true, you probably want to wait until you get some better data before you change anything based on the report. It's a best practice to sit down with the patient and review it together. Again, it's a conversation. It's a tool that helps patient engagement in their care. It can be very eye-opening to look at, the patterns of glycemic control depending on lifestyle. And then you're going to identify, okay, when did you eat? When did you exercise? When were you asleep? When did you take your meds? And then look at kind of the corresponding change in the interstitial glucose. And then you're going to look for patterns. Oh, geez, why are you so high in the morning? Maybe, we need to increase your basal insulin, something like that. Is there hypoglycemia? What happened? Did you skip breakfast? Did you, miscalculate your insulin? I don't know. What's going on? You'll make an action plan based on the data that you find, and then you document your interpretation. We have this dot phrase right here, the CGM RPM interpretation note, and this actually will help you ping you to put in your interpretation and any changes to the care plan, and it'll meet criteria for billing out the interpretation code. And I'll show you a table where it has the billing and coding information in the next few slides. And then you're going to CC your chart to the RN and RD so they know what's on your mind and they can help you, follow up with the patient, check in with the patient. They know when you want to get the next download from LibreView, et cetera. So changes to care plan, there's always like a lot of between visit care that happens. And, one thing that we actually found in the pilot was that participation in these plans can actually remove the need for a face-to-face appointment, which is great. I mean, especially in this day and age where, we're really trying to decrease the amount of foot traffic in and out of our clinics, et cetera. So we have a dot phrase for the RN and RD to use. It's the CGM RPN RN follow-up visit. And, your RNs and RDs are going to be doing a lot behind the scenes. They'll be, facilitating the data downloads and uploads into Epic. They'll be, communicating with the patient, et cetera. And all of that time is actually billable for them. They can bill for time spent just going into LibreView, downloading the report and putting in Epic. No live communication with the patient is required to bill out those time-based codes. Additionally, this is what I mentioned before. So you will be interpreting the AGP reports, and you can bill this out up to once every 30 days. You'll use that smart text. And then we also have a treatment AVS. This is kind of for patient instructions as you go through the program. It just allows you to summarize care plans, et cetera, and make sure that, communication is clear with your patients. And then in between, you'll be getting e-care message, phone calls, et cetera, kind of CC'd to you from your RN and RDs. This is the billing coding grid that we're using, and you can see the code, what it's for, whether it's time-based or not, and who's going to use it. I would say predominantly you guys as providers are basically only going to use this 95251, which is the interpretation. This is the smart text that goes along with it, and it's billed out every 30 days. The rest of the codes are really going to be used more by your support staff as they kind of help tee up the care for the patient. We have a job aid that's really comprehensive, and it has screenshots. It has kind of bullet points going through every part of the process. And so we'll make sure that your clinic has this information. There might be some attachments in here that you might want to print and just have it at your desk. So for instance, the billing and coding summary table or the smart text summary. So you can just remember what the dot phrases are called in Epic. And then, you could even print the whole thing if you wanted. It's only 8 pages long. Here's the links to the other resources that I mentioned. So Savisa's a really great lecture going through in detail how to interpret AGP reports. The link to the RPM job aid, the full toolkit is right there. And then the link to the training video from Abbott, if you want to, a little bit more of an abbreviated go through of AGP reports. This is a aggregated list of all the dot phrases that we've built, and they're all live and in Epic. If you do have problems accessing them, please let us know. We've had a few little pockets of people. For most people, they can access it, but anyways, if you have it, please let us know and we'll figure out why you don't have them. But this is what we have for Epic Tools. And I think I've got 5 more minutes left. I'm happy to answer questions. Yeah, Penny, are you raising your hand?
Oh yeah. Will there be a smart set built?
Yeah, so that's a good question. We have really limited IT resources right now. I do think that smart sets are something that can be very helpful. I think honestly what would be better is if we actually get the integrated toolkit. There's actually an Epic RPM toolkit that integrates through MyChart to devices. And actually, as a side background, I actually have a meeting with IT to talk through next steps on doing that. And so right now, this is kind of a patchwork version. I think it's a good enough service to want to offer, and our patients are asking for it. In fact, I offered this to a patient last week who was just diagnosed with diabetes, and she was like, "Oh yeah, I've seen like 10 commercials for that like in the past week." Like, oh, okay, so it's out there, so we want to do it. But yes, better tools are on their way.
And will you be sending a copy of your PowerPoint, or I guess at least links for the smart phrases so I can copy?
Yeah, Mika, I think, did Teresa already get all of this in the first email a little while ago? But we'll make sure you guys get it.
Perfect,
Yeah.
thank you.
I will also send a recording of this presentation to everybody.
And then just also, some, just information. We are having I don't know what we're officially call it. I'm going to call it RPM office hours, where one of us on the leadership team will be sitting on Zoom, if people have questions. And I think those are already on the calendar, right, Mika? I think those are booked.
Correct. Yeah, on Wednesdays.
Yeah. Yeah, and then, the other question is, oh, when does this go live? Well, it's actually live now. All the tools are available in Epic already. All of the billers and coders are aware that these codes are going to start getting dropped by clinics. The RN and RD training has already happened. So, you can actually start offering it now. You might want to have a OPMC clinic, specific conversation just about, making sure that everyone in clinic is aware that this is going live, but everything's ready, good to go when you guys are ready to start offering it to patients.
I have another question.
I'll also just mention, yeah, go for it, Penny.
Oh, sorry. Will we be getting continuous blood pressure support too?
Good question. So we actually have a hypertension program that's good to go. When I was planning rollout with Vicki and Deborah and Chantal and Tammy and a lot of the executive leadership, we wanted to focus on CGM first because of a lot of our pop health, programs, our value-based contracts, and also that this really allows us to partner with the RDs more. One thing that as we were planning, a lot of times what happens, unfortunately, are these programs are really based around one key staff member, like the RN, and then if the clinic doesn't have an RN, there's no backup. And this allowed us to at least have a little bit of cross coverage with RN and RDs in a team-based program. So we wanted to go live with that first. I totally have a hypertension program that's basically good to go, but we're going to get this off the ground first, and then we will come back. That's why if you look at the RPM referral, it does have the drop down to hypertension as well, and why we're trying to make the tools as generic as possible, because we anticipate more programs offering RPM in the future.
Great, thank you. That's great to look forward to.
Yeah. And I was just going to mention about reimbursement. So, we had a pilot program with hypertension and CGM. And in the 2 pilots, I believe we had about 35 patients enrolled total. And, we've collected over $8,000 just from those small pilots. So it's like real money. And hopefully as we integrate more programs like this that are team-based that really take the revenue out or find new revenue streams besides, just grinding out more and more appointments, we can really transform the way we provide care for patients and make it, a little bit more sustainable, less burnout prone. But anyways, you guys know how to reach me if you need anything. If questions come up, let us know. If you definitely have any problems with the Epic tools, let us know. But I'll let you guys get on with your afternoon. You guys have a wonderful weekend, and I'll look forward to seeing how this goes at OPMC.
Great. Thanks, Crystal.
Thank you so much. Appreciate it.
Yeah, thanks, guys. Okay, bye.
Bye.